like to bring Dr. Dowd up, and Dr. Dowd's been at UCSF for several years now. Really enjoyed interacting with him over the years. He's been a good mentor for bouncing things off and thinking about where we want to go. And he's been a leader at the UC Melanoma Skin Cancer Consortium. So thank you, Dr. Dowd, for doing this.
I'm excited to be here and excited to be part of this great program. Thank you, Dr. Daniels, and thanks to AIM for organizing this and Paige. So yeah, So what and it was great to hear Dr. Chimlowski and Scott and Lyndon too today. But what people think today is that the way anti-tumor immunity works is that there's a process where your immune system senses cancer, and I wouldn't say that it's totally clear how that happens, because as Dr. Chimlowski was saying, there's differences between cancer and between your body, but it isn't totally clear what needs to happen for your body to sense that. But we think tumor antigens play some role. Those tumor antigens are shed and they're picked up by dendritic cells. These are cells in your skin and in the rest of your body that sense changes in your body. And then these dendritic cells then basically go to the lymph nodes. And then at the lymph nodes, they essentially just lie in wait, sometimes for years, waiting for the right T cell. And remember, each T cell only makes one kind of T cell receptor or one kind of antibody in the case of B cells. So you basically are waiting for that match to happen in the lymph node. And sometimes that takes a while. But once it happens, the T cells get activated, they go back into the tumor. And then once they go back in the tumor, they start killing tumor cells. And so what we've learned over the last few years, that if you look, for example, at the response of different types of cancers to immunotherapy, it does seem like there's a certain level at which most cancers will respond to immunotherapy. So like, for example, if you look at skin cancer, if you look at squamous cell, basal cell, melanoma, Merkel cell, they all have this around like a 40% response rate to immunotherapy. And if you look at kidney cancer, it's about 20%. If you look at lung cancer, it's about maybe 15 to 20%. And then if you look at the very extreme end here, like prostate cancer, pancreatic cancer, it's low. It's not zero, but they don't often respond to immunotherapy very well. And I think where we stand today with immunotherapy is informed a lot by this Checkmate 67 study, where basically patients with melanoma were randomized to either nivolumab plus ipilimumab, that's the orange box, versus nivolumab alone or ipilimumab alone. And basically that's where we stand today. That if you look at the combination of nivolumab and ipilimumab, it's about 52% or about 50%, even out to 6 years. And as Dr. Chimlowski was saying, basically we are talking about this space here at the top, where if you had 100% survival, you'll be here. And we're talking about the 50% of people who don't have a response today with combination immunotherapy. And if you look at different types of melanoma, not all respond as well to combination immunotherapy, and some respond better. Like, for example, if you have wild type BRAF, so non-BRAF mutant melanoma, it seems like you do just about as well from just nivolumab or nivolumab plus ipilimumab, while if you have a BRAF mutant melanoma, it seems like you get some benefit, like maybe about 14% from the nivolumab plus ipilimumab combination. And if you look across the spectrum of immunotherapies, and if you just look at what price are you paying for your response, and in our jargon, that's called side effects or grade 3 or 4 side effects. So the higher you are up here, the more you have autoimmune side effects like lung inflammation, skin inflammation, liver inflammation, etc. And the better you're at this end, the more effective the immunotherapy is. So you could see that there is a general trend that the more effective the immunotherapy, the more side effects you have. But it isn't like a perfect, kind of like a, regression. Like you could definitely see that, some types of treatments, like for example, this combination of relatlimab and nivolumab, you could see that you could get pretty good responses, but you're not getting a lot of side effects with that. While over here, you're getting, with Checkmate 67, with Nivo-Ipi, with the high dose Nivo-Ipi, you're getting pretty good response rates, but you are also getting 50 to 60% of people developing severe side effects. So in some cases, I think you're paying a lot for the side effects, for the response that you're getting. And in general, the more PD-L1 staining you have, the better your response is going to be. And this is a study from several years ago. But if you have a tumor that has a lot of PD-L1, like right here, the response rate is going to be 50%. While if you have a tumor that's here, like 0%, you're going to have maybe 10% response. So, like Dr. Chmielewski was saying, it's not like 100% concordance, and it's not like a red light, green light kind of thing. But there is some relationship between response and between PD-L1 staining. And it's also known that it's not just the tumor. It doesn't even matter what the tumor is. Regardless of the tumor, there's factors that are known to affect immune response. Like, for example, things like obesity, age, microbiome, what kind of gut flora you have, your gender, the bulk of your tumor, how big the tumor size is, that informs the response rate. And, back a few years ago, we looked at things like liver metastases, and we looked at the centers on the West Coast, UCLA and UCSF and Angeles Clinic. And basically what we found is that the presence of liver involvement and we're talking skin melanoma, so we're not talking uveal melanoma, which is known to have a predilection for liver involvement. But even in skin melanoma, if you had liver metastases, things were less likely to respond to immunotherapy as compared to if you didn't have that. And if you look at what are known as spider plots, so basically each of these lines is one patient, and these are patients these are many hundreds of patients who were treated with PD-1. And if you look to see how their scans evolve over time, you'll see this general pattern. Like, for example, if you look at this paper, Clinical Cancer Research 2017, each of these is a line. And for example, if you look at most patients, they'll either have a response in the first few weeks of treatment or not at all. It's rare for somebody to go along this way, like this patient here, who went along with no real response for about 15 months and then suddenly had a response. That is not the common pattern. The more common pattern is have a response and then gradually it gets better over time, or else to not have a response at all. And I feel like you could divide the responses into these stages. Like, you have this initial ignition stage, and then over time it can get more complete and more more stronger. And then if you watch those patients for years, you'll see that sometimes that response will go from like 90% to 99% to 100% over time. And that has led to this issue of how exactly that's going on and what is the mechanism behind this. And I think what best explains that, which I'm just going to cover in the next slide or two, is that you basically have T cells that fight against the tumor, but they don't have, they don't have the longevity to keep doing that over time. And you need to get fresh T cells into your tumor to complete the job. And that is like a factor in immunotherapy. And I think that's interesting when we talk about TIL therapy, where you're taking T cells from a tumor and then growing them out. That was approval that just happened yesterday for regrowing those in a petri dish and putting those back and trying to see like how effective that is. So what's our next step? Well, there's a lot of drugs that are being experimented on, lots of interesting drugs. And I have to say that generally, if you look at all of those numbers, like for example, T cell therapy is, the adoptive T cell therapy has a, back in the day that I made this slide, had a 38% response rate. Now it's more like 20 to 30%, I would say. But if you look at the numbers here, a lot of times the numbers are not as high as it is for PD-1 therapy. And part of the reason is that PD-1 does so much of the work in response that the added treatments often will give you only like say 10% response rate or something in that range. And so where are the places where we can make a difference? I think one of the places is right here at the tumor microenvironment where, as Dr. Chimowski was saying, you can basically use vaccines and you could use other technologies to try to make the tumor more visible to the immune system. And I'd say that the even more active area of investigation is in the lymph node and at the tumor microenvironment, where we have these what are known as co-stimulation checkpoints or co-stimulatory checkpoints. And they are things like TIGIT, LAG3, CD47, and then what are known as the TNF superfamily, and that's receptors like GITR, 4-1BB, and OX40. So if you think about T cells have brakes on them. And one approach to immune therapy is to just get rid of the brakes. And that's basically what PD-1 is. That's what CTLA-4 is. That's what LAG3 is. That's what TIM-3 is. But another class of molecules on T cells, you could think of them as steering wheels. They don't necessarily brake, or they're not gas pedals, but they change the direction of T cells. And that's the TNF receptor superfamily. And that's where these 4-1BB and OX40 and some of these other checkpoints are involved. So if you look at that first, this area right here, making your tumor more visible, as this is a trial that Dr. Chimowski mentioned. It's basically a cancer vaccine trial, and cancer vaccines, I think the long and short of it is that they haven't been successful. They haven't worked for us. They've been tested for 20 years. But looking back at them, one problem with them might have been that, we are just using off-the-shelf vaccines. We're giving the same vaccine to you as we're giving to this other person, as we are giving to this other person. And the problem might have been that we just simply didn't personalize them. And we honestly didn't have the technology to even do that until recently, until COVID. And so what Moderna and Merck have done is basically personalize those vaccines, get the tumor, sequence them, find the neoantigens, make them into an mRNA vaccine, then give that mRNA vaccine in addition to pembrolizumab, which is the PD-1 drug. And that was what this trial was. It was a 2-to-1 randomization, and this was the graph that Dr. Chimowski showed. It basically showed that there was a major improvement compared to just giving pembrolizumab. So remember, pembrolizumab already cuts the risk of recurrence down by 40% or 40 to 50%, as Dr. Chimowski was saying. So the fact that you're getting this added benefit to pembrolizumab is something. It's already better than nothing. So I think we'll have to see how that goes. I think one of the criticisms of that trial that I've heard before is that because patients who have a lot of neoantigens have tumors that are much more, immunogenic, you can have a situation where it's the fact that the patient has so many neoantigens that itself gives you a better response. So what happened in this trial is that it was a 2-to-1 randomization. And if we couldn't make the vaccine for you, you got put into the pembrolizumab arm. And so there could be some imbalances and there could be some issues with this. So even though it sounds like a 150 patient trial is a pretty good piece of data, actually, there's only 50 patients in the pembrolizumab arm. There was 100 patients in the vaccine arm. And so there could be some imbalances. And so now the next trial is going to have 1,000 patients. So we'll see how that pans out. And so let's take a look at some of these other checkpoints, like the co-stimulatory checkpoints. And so the one study that was presented at the ASCO meeting last year was looking at TIM3, and it's another one of these checkpoints right here. It's a break on T cells, and you could basically take that break out just like you can take PD-1 out. And so this was a study that was presented by Dr. Rebus, works with Dr. Shimlowski. And so this is the results from that study. And like you could see here, all of these bars going down, that just shows the percentage reduction in the tumor. And so you could see that, several patients developed responses, and some patients had some pretty major responses. And then if you look at those spider plots, you could see that seems like, even 50, 60 weeks from treatment, patients had continued to have responses. I think the one issue with this study was that patients had not, in many cases, had not received PD-1 before. So that was the problem, that we didn't, from this trial, it's hard to say how much of a response you were getting from the TIM3 blockade and how much you were getting from PD-1. So it remains to be seen, and we'll see in future trials how much TIM3 really contributes. And so the plan is to do more studies in patients in whom PD-1 didn't work, so that we could see how effective it is. And then we looked at this study, which was also opened at UC Irvine, which looking at 4-1BB, and this is our results. So these were patients who had progressed on melanoma, and these were patients who had in many cases had multiple lines of therapy, and some patients had great responses. And like, for example, this is a patient of ours who had a mucosal melanoma, and you could see that before treatment, she had this enormous tumor, like lots of disease. After treatment, nice response, and she's now a year and a half out, and it has a complete response. And then this is a patient, again, with mucosal melanoma. It just so happens had liver lesions, and you could see that the liver lesions disappeared after some time. So I think one of the issues with these studies, and I think that's a weakness of this study too, is that we have to see in today's landscape, how does that fit in? Are we going to add it on to, things like Ipi/Nivo? Are we going to give it by itself? Are we going to give it with PD-1, or what? And what are the biomarkers that could predict for responses to this agent, which I don't think we know that for a fact right now. And the same drug was tested in lung cancer, and 2 patients out of 14 had responses, even though they previously hadn't responded to PD-1 before. And another interesting molecule is something called TIGIT. Again, it's one of the same, it's in that TNF receptor family. So it could be like a steering wheel, not necessarily a brake on T cells. And so the TIGIT drug was developed in various settings, and Genentech had one version of that drug. And so they did a trial in lung cancer where they combined it with PD-L1. And you could see that in this randomized trial, it seemed like it doubled response rates in patients with lung cancer, and a nice advantage, over placebo. That's the blue arm. But unfortunately, when they took it to a larger trial, just like we are talking about with the mRNA vaccine, called Skyscraper 02, in a different disease setting, really no advantage in that trial. Like the primary analysis did not show a difference, and actually you could, when you look at this closely, you can see that there's a difference between the blue and the red, except that the blue is actually the placebo. So the placebo is actually better than the experimental arm. So really not showing much of a benefit. You don't want to see that type of trial where the control arm does better than the experimental arm, because that's not showing a success. And the same pathway but different drug is being studied in melanoma as well. And in this study that was presented a few months ago, it's called this Keymaker 02 study. And here, this was like Dr. Shimlowski was saying, it was like a neoadjuvant trial, meaning like you could have surgery, but instead of having surgery, you were given some immunotherapy first. And the idea was to see how your response would be. And then you would, proceed to surgery. And that one thing we could say about this drug is that it doesn't cause a lot of side effects. Like, for example, if you look at itching or pruritus, there was maybe about 10% more, but generally speaking, not a lot more in the TIGIT arm. And if you look at the response rate, which is the bottom line, if you compare this arm 1 to arm 3, arm 3 is just pembrolizumab and arm 1 is the combination. You can see that maybe you had like about a 7% more response rate in, compared to just the pembrolizumab alone. So, we'll have to see how that translates into in a larger trial. And what's known is that if you look at pathologic response, like for instance, if the pathologist looks at the slides versus if you look at the response rate, there's some concordance between that. And so like if you look at the TIGIT arm, you could see all of these patients had responses. If you look at the pembro alone, you got a lot of responses there too, but maybe not as much as with the arm that had the combination treatment. And there's other drugs. Not totally sure why this got translated into Chinese, but I don't honestly speak Chinese. That definitely wasn't something I made, but you'll have to trust me that it's a drug that is being explored, and it is showing some promise, but we'll have to see how exactly that translates into in real life. And so yeah, I'm excited to be here and excited to be here for our second annual meeting. And so yeah, there's a lot of promise with different types of therapies. There's the novel mRNA vaccine technology. There's all these different checkpoints, and some of these are ready for trials. I think one of the challenges that we've had is that without today, there's just so many drugs out there and a limited number of trials that you can consider, and you have to be able to predict somewhat who is going to respond to what type of treatment before you start doing that. We haven't even talked about targeted therapy, which is a big feature in our disease. There are NRAS inhibitors. There's the inhibitors for uveal melanoma that Dr. Shimlowski was talking about. But in addition, there's a lot of immunotherapies, and it's almost a difficult thing to decide who to treat with what type of immunotherapy. So with that, I'm going to end and